This is going to be a review of the long lesions and is there a standard out there. These are all of my disclosures. So you're going to see a lot of stent designs and stent trials, but they have come out with registries and some of the reasonably good data set for 20 centimeters or longer, where we live and breathe in most of the SFA data set that we see every day is in those longer lesion subsets, and they become more complex. Long lesion trials or protocols, unfortunately, have become scarce or scarcer. They become secondary to the pivotal trial. And the outcomes on head-to-head comparators are even fewer and more difficult to then discern. So for this topic, I think what we only can do is start looking at the data set as presented, either in pivotal or in registry form, and then kind of glean some information. This is a Supera study which shows that at nominal deployment, when the vessel is pre-dilated adequately and prepared adequately for the delivery of the Supera stent, this is from freedom of TLR, so clinically driven endpoints, that they do very well both at 1, 2, and 3 years. If the vessel is ill-prepared and the stent becomes elongated, it performs very poorly. But this is in an 8 centimeter metric for its registry trial, the Supera study, superb study. But in the longest lesions, which went up to about 20 centimeters, the primary patency from this IDE trial at the shortest, medium, and long lesions, this stent, when deployed adequately, performs exceedingly well in both those short, medium, and long lesions. And it's actually a fairly good performer over time beyond that. And you can see that the clinically driven TLR from Superb on long lesions do better than, we don't have time for us to go through the bare metal self-expanding stents that have come before it at the 3-year mark. There's a clear decline in success from a clinically driven endpoint. The other alternative for trial design, and to Gore's benefit, the Viabahn has done really remarkably well, and they've put a lot of effort into proving the 19 and 20 centimeter lesion lengths. From Vibrant, which was a negative trial, came Viper, which was a registry at 19 centimeters with calcification in a fair amount that was moderate to severe. And their primary outcome of patency with ultrasound-guided patency was 74% across the 5, 6, and 7 millimeter devices, with primary patency clearly better with a wider graft. And that, again, goes along with what you would expect from a bypass patient population. A bigger graft is going to perform better. On the heels of that came Viastar, which was a randomization between the Viabahn to a bare metal stent. This again was 19 centimeters, and clearly the Viabahn performed better at the inception at 1 year primary patency, and also stratified to lesion length. They also did quite well, again from a loss of patency compared with the bare metal stent. When one looks, there's always this question about Viabahns having an issue with acute complications or occlusions. Almost invariably, all of their trials have suggested that is not the case. Only had a few acute events, and these acute events did not statistically differ from the bare metal stent. And principally, although I haven't seen it proven clinically to be a benefit, the edge restenosis occurs more often in the Viabahn as opposed to diffuse restenosis within the bare metal stent. And then you can see the exceedingly long data set is out to 70% or 67% out to 12 months in the very long 25 centimeter lesions. There's a myriad of drug-coated balloons. We've seen several presented already. The IN.PACT has gone out to 3 years. You've seen this in both primary patency as well as TLR. But the registry data on the global cohort had long lesion de novo in-stent restenosis, and I really want to look at the complex lesions of 15 centimeters very briefly. 17 centimeters, this was presented and published. Marianne Brodman was the principal author. Understand that this is in-stent restenosis. They still re-stented in about 15% of these patient populations. The global cohort had a primary patency, however, very similar to the pivotal trial at around 90%, 89%, which is a remarkable number, and then the TLR is equally quite good. In their longer lesion cohort of 26 centimeters, the use of stents goes proportionately higher Now it's 50-50 shot in this registry that you would have to use a stent. However, their primary patency in these complex lesions, now at 28 centimeters, is again a fairly consistent 89%, understanding, of course, that more of these patients also had endoprosthetics placed. There is the Macari paper, which was a single-center Italian registry at a 25-centimeter lesion length with a primary patency, now about half that number, even less than half, about one-third the number of stents placed. That was around 71% at the end of 12 months. And their very long versus long lesions had no difference overall between the two groups. And this probably was due to a much better vessel preparation with predetermined predilatation to prepare the vessels. And then this is the lesion lengths as time goes on with Illuminate at 3 years, again, only an 8-centimeter metric. I just want to briefly show you the Lutonix registry. You've seen the pivotal, Bill just presented it. This is their registry data at 21 centimeters in lesion length, and they have a freedom from TLR at 87% at the 1 year and 75% at the 2 year. So although the pivotal was relatively flat, the registry data seems to be clearly better. So when one looks at the SFA and long lesions, what have we learned? I think the biggest issue with any endoprosthetic is restenosis. Endograft therapy appears attractive from all the data. The issues with compression, like surgical bypass, I think are very important and must be taken into account. Interwoven design stents appear safe and effective at most all lesion lengths. DCBs, without a doubt, despite the issues going on with the FDA, have dramatically changed the SFA landscape, and I think their global data to long lesions and CTOs are actually useful. There is, however, this interesting increase in endoprosthetic placement, which, again, we have to take into account. But critically, no scientific data on head-to-head comparators at this lesion length have, at least from what I could see, is available. But the initial therapy is at our discretion what you want to use. You can make it look pretty with an endoprosthetic, or you can take your hits with DCB, understanding the benefit of it long-term. And restenosis options still remain, whether it's in-stent restenosis or de novo restenosis from a DCB. Thank you for your attention.